Thank you very much for the introduction. I would like to talk today about progestin-primed ovarian stimulation, multi-stim in advanced fertilization. This is a new concept. The outlines of this presentation will be the challenges of advanced maternal age and the need to have an individualized approach in management. And we'll compare PPOS, which is progestin-primed ovarian stimulation, with the antagonist, and the Duo-stim, the original Duo-stim, which is done by the antagonist, versus the Duo-stim that can be done with the PPOS, and lastly, the PPOS multi-stim. And then we'll talk about how will progestin prevent LH surge, the advantages of PPOS, and what are the types of progestins and doses, and the comparison between PPOS and antagonist as regards the response and outcome. The same for the agonist, and the effect of PPOS on oocytes and embryo quality, and lately the PPOS effect on obstetric and neonatal outcome and the cost effectiveness and conclusions. The challenges of advanced maternal age are, of course, first, as we know, the poor response and the decreased euploity rate. Therefore, the number of oocytes that are needed to obtain one euploid blast is relatively high, and in most patients can only be achieved after multiple ICSI cycles. For example, we will need about 20 oocytes to get one euploid blast above the age of 40. Moreover, the time to pregnancy is unduly prolonged. This is due to the multiple cycles that are tried and the intervals between the cycles. And hence, we have a very high dropout rate in advanced maternal age attempting pregnancy. The individualized approach is mandatory because there is no standard management that has been validated for advanced maternal age management. And this should be tailored to each couple's specific characteristics and condition. Duo-stim is useful for patients who might benefit from increasing the number of oocytes to retrieve to maximize the cumulative live birth rate per intention to treat. And Duo-stim is usually combined with PGTA and single euploid blast Swiss transfer. Duo-stim seems to reduce the time to obtain one euploid blast and to avoid multiple failed implantations, miscarriages, and treatment discontinuation. And Duo-stim protocol uses the antagonist in the first follicular phase, as we know, but not necessarily in the second part of the stimulation in the luteal phase. PPOS, on the other hand, can replace the antagonist in both the follicular and luteal phase in the Duo-stim protocol. The number of stimulation cycles needed to obtain one euploid blast may far exceed the classical 2 cycles of Duo-stim. So we can do successive PPOS cycles, which we call multi-stim. It can be continued until you achieve one euploid blast. Similarly, patients desiring more than one child can continue until they get the desired number of euploid blasts that will give them a chance to have more than one child. So if we look at this figure, this is the antagonist down. We start the antagonist on day 6 classically of the stimulation, while in PPOS you can start on day 1 or 2 of the stimulation, or with the flexible PPOS you can start on the 7th day of stimulation. And here is the Duo-stim protocol, the original classical Duo-stim protocol, where the antagonist is used in the first follicular phase cycle, in the first follicular phase here, and then you do the OR, then you do the oocyte retrieval, and then you have a 5-day interval waiting until you start the second stimulation, and no need to give the antagonist so long you have no menses. And this is the Duo-stim with the PPOS, where you start your stimulation with the progestin, give agonist trigger, do your ovum pickup, 5 days interval, continuing the progestin, and start your stimulation of the second cycle after that. And this is how to compare both together. And this is the new concept of the multi-stim protocol, PPOS multi-stim protocol. You continue the progestin all through the stimulation. When you give the gonadotropins, give the agonist trigger, do the ovum pickup, 5 days interval, then start another stimulation, the same and the same and the same until you get the desired number of oocytes that you want. How does progestin prevent LH surge? The exact mechanism is not fully understood. However, progestins in relatively high dose block the transmission of estradiol stimulatory signal to the hypothalamus and decrease the frequency of GnRH pulses. In this way, agonist trigger can still work and can induce ovulation. The advantages of PPS appear to be very simple. It's cheaper, simpler, less injections, multiple successive stimulation can be done within a short time, and more importantly, they have similar outcomes. And what type of progestin? Which dose? Actually, any type of progestin can be used. The most commonly used is medroxyprogesterone as status 10 milligrams or dydrogesterone 20 milligrams or the micronized progesterone. However, you can still use noritestosterone, Dinogest, Norgestrel, and so on. And which dose? Actually, studies comparing the low dose and the high dose were similarly effective. So you can use the smaller dose in the same efficient way. PPS versus the antagonist. We'll compare them as regards the response to stimulation. So we'll look at the duration of stimulation, the gonadotropin dose, number of oocytes, and number of M2 oocytes. And in this meta-analysis, we find that all these parameters are similar in both protocols. So there is high-quality evidence supporting the effectiveness of PPS as regards the response to stimulation compared to the antagonist. What about the outcomes? Because we have two separate cycles, the stimulation cycle and transfer cycle. As regards the transfer cycle, we'll compare the effectiveness of progestin compared to antagonists as regards live birth rate per woman and per transfer, and the clinical pregnancy rate and the multiple pregnancy rate and miscarriage rates. And this meta-analysis truly shows that both are equally effective. So PPS is as effective as the antagonist in the outcomes. However, the evidence is weak because of the bias that's present in many of the studies. PPS versus the agonist, we have few studies comparing the PPS with the long and the short agonist protocol. Also comparing this, the side of the response to ovarian stimulation, this meta-analysis shows that they are both equal and the quality of evidence is low anyway. However, if we carefully look, we'll find that the short agonist protocol consumes less gonadotropics and has a shorter time than the PPS, and the PPS has lower dose of gonadotropin and shorter duration of stimulation compared to the long agonist. As regards the embryo transfer outcome, regarding the live birth rate per embryo transfer, live birth rate or ongoing pregnancy per embryo transfer, clinical pregnancy rate, miscarriages, and multiple pregnancy rate, this meta-analysis shows that the PPS is as effective as the agonist stimulation protocol. However, the evidence is low. What is the effect of PPS on embryo quality and oocyte quality? Of course, we have some concern about the prolonged exposure of the follicular phase during stimulation to progestin, and there are some concerns that has been raised about the quality of the embryos that we obtain in the antagonist cycle when you have high progesterone in the phase on the day of HCG, that might affect the quality of top quality embryos. However, studies have confirmed that PPS does not affect the quality of the oocytes in the embryos, as it has been shown that the euploidy rate with PPS is as good as the antagonist protocol. So there is no effect on the euploidy rate of the embryos. What about the effect of PPS on obstetric and neonatal outcome? Actually, antagonist and PPS has shown similar obstetric outcome as regards the rate of low birth weight, preterm birth, small gestational age, and major congenital anomalies. So what about cost effectiveness? Of course, if the intention is to do fresh embryo transfer, the antagonist or the agonist protocol will be more cost effective. But if you intend to do freeze-all for PGTA, for embryo accumulation, for whatever reason, then the PPS will be the protocol of choice. because it will be simpler and more cost-effective. So in conclusion, PPOS multi-stim combined with PGTA is a novel, simple, patient-friendly, cost-effective protocol that allows multiple successive ovarian stimulations for advanced maternal age patients. It markedly reduces the time to pregnancy. It shortens the time to pregnancy. It shortens time to obtain an euploid blast, decreases the number of embryo transfers needed to obtain a live birth, and avoids multiple or increased miscarriages, and avoids one of the main drawbacks of advanced maternal age treatment, which is the dropout, discontinuation of treatment. PPOS compared to agonists and antagonists have similar response to ovarian stimulation and similar embryo transfer outcomes. Thank you very much.